Hello, this is David Bishai, and this is the lecture on the economics of malpractice. In this lecture, we will be discussing the goals of the malpractice system, the law and economics framework, economic perspectives, and in those perspectives, we'll discuss Coase theorem and how it applies to the concept of deterring externalities. We'll talk about defensive medicine as a reaction to the malpractice system and how defensive medicine can increase the costs of healthcare. Finally, we'll look at malpractice insurance and bring back our understanding of experience rating. And we'll talk about the crises in the malpractice system that will recur repeatedly. So let's talk first about some definitions in malpractice. First definition is what is an adverse outcome? And that is basically something bad happened. There was bodily harm, mental harm, there was deception of a patient, or there was battery, which was doing something to the patient without permission. Not all adverse outcomes in healthcare are caused by intention. They're not caused by acts of intentional decisions to commit an act or decisions to omit an act. However, when adverse outcomes do occur, the system seems to react worse to acts of commission, where there was an intention to do something, and less likely to react to an omitted act. So, for instance, if one dies from a surgeon's decision not to operate, there's less likely to be malpractice than when there's a decision to go in and operate on an inoperable patient. More definitions. We need to define what an error is. An error is a medical term, not a legal term. This is the failure of a planned action to result in the intended medical outcome. Next, we'll define a legal term, negligence. Negligence is what courts can decide. And when a court decides that there is negligence, they are saying that there was a preventable adverse outcome caused by the physician's failure to follow a standard of care. Well, what's a standard of care? The standard of care used to be whatever the local jury or judge would decide, and they would call in local experts. These days, however, plaintiffs' attorneys will call in national expert opinion, and so the local community standard is giving way to a national standard. So let's give some cases to try to get the difference between adverse outcomes, negligence, and error. Here's case one. Here's Mrs. G, and she has a feeding tube that comes out. The doctor inserts a new feeding tube, but it does not go into her stomach. So it's temporarily probably in her lungs. So what could happen next? Well, in this case, a nurse at the nursing home gets an x-ray to identify the location of the feeding tube, and she finds that the tube is in the lungs. The nurse calls, and the tube is repositioned, and Mrs. G, fortunately, does not have any adverse outcome because she doesn't get any food in her lungs. So that was neither negligence nor an adverse outcome, but it was an error. Case two. Here's an adverse outcome. And in this case, Mrs. G's feeding tube comes out, Dr. Q inserts a new one, and it goes into her lungs. However, unfortunately, she is fed through the feeding tube. The food goes into her lungs, she chokes and coughs, and has an adverse outcome. It's bad to have feeding solution in your lungs. So she actually gets a fever, but she doesn't get that sick. She gets pneumonia and goes home and doesn't die. So this is definitely an adverse outcome. It is also an error. However, if this isn't litigated and never goes to court, it cannot be negligence, because it can only become negligence if a court decides that there was a failure to adopt the standard of care. So finally, let's go through negligence. Same thing, feeding tube goes into the lungs. Mrs. G is fed, she chokes and coughs, and then she dies a week later. Now the question is, is this really negligence? And it is negligence if the court looks at the case and finds that Dr. Q violated accepted standards of care. And Clearly, it's quite likely that the court would find that this was negligence. Most expert witnesses would say that this was a violation of the standards of care. However, if the family never sues, or if for some unforeseen reason the plaintiff's attorney loses the case, this would not be called negligence. So negligence is a legal term. However, error is a medical term, and adverse outcome is sort of the facts about the world, that something bad happened to a patient. So let's go through a Venn diagram of the differences between adverse outcomes in the red circle, errors in the green circle, lawsuits in the two rectangles, and awarded lawsuits in the upper rectangle. And I wanted to go through a diagram of where these things fall. So I wanted to show you this map of the various spaces of the things that can happen in malpractice. So let's go through this Venn diagram. We'll start with space A. What's happening in A, in this whole red circle, are adverse outcomes. But space A is an adverse outcome that could not be affected by medical care, because this is adverse outcomes not related to errors. So here there's no error, there's no lawsuit, it's just bad stuff that happens to people's bodies. If we go to the other part of the adverse outcome, here are adverse outcomes that have lawsuits attached to them. And in space B, there's an adverse outcome, there's a lawsuit, and there is no error, but the suit is awarded anyway. So this is something where we would really not be so thrilled that this is happening, because the medical system is being punished for an adverse outcome that was not the result of an error. In space D, next to space B, there was a lawsuit, and there was an error, and there was an awarded suit. So we're really happy that this space is happening. We want there to be awarded suits when there are errors. In space C, there's no error and the suit is dismissed, and so this is also a good thing. We want the court to decide that there's no grounds for negligence whenever there's no error. In space E, we have the case where the suit is dismissed and there's an error, and this is also unfortunate. We want the court to get it right and to find that there is negligence whenever there's an error. So this interface between where there are errors and where there are adverse outcomes, we would like most of these overlapping green and red areas to result in an awarded suit. And the coloring of on the right-hand side of the legend is trying to flag to us where we want things to happen and where we don't. The green colored spaces of A, C, and D are what we want the system to do. And the red colored spaces of B, E, and F are mistakes in the malpractice system, things that we don't want. Finally, I didn't mention this, but in space G, we have errors where there was no adverse outcome. And this would be, as mentioned earlier, where the tube goes into the wrong place, but the error is detected, the system corrects it, and the patient is saved without any adverse outcome. We would like G to occur a lot, but that's a question for the medical care system. So if we go through this diagram, we have several goals that we would like to accomplish in the malpractice system. To be fair to doctors, we want area B to be small. We want them to not be awarded malpractice suits when they don't make errors. When we want to think about fairness to patients, we want to make E small. We want patients to be awarded malpractice when they are the victims of errors that are related to adverse outcomes. We also want to generally deter errors. We want the entire green circle to become small. We want there to be more care and attention to safety in the system. There's another goal, though, of compensation. There is a ongoing idea that if you become injured, you deserve compensation. And so we would like to make compensation to the injured occur whenever it is due. And in order to accomplish that, we want all of A, C, E, and F become small, and we want awards to occur in space D to compensate the injured. Now, lawyers want to basically win lawsuits, so if you are working to reform the system to improve payments to trial attorneys, you just want to win more awards. If you are working to reform the system for the medical sector's interest, you want awards to not occur, and so you want B, C, D, and E to be small. Patients want there to be no errors, and I think this is sort of the social interest, is to make everything in the green circle become small. And society's interest is to mitigate the catastrophic consequences to patients. We want all of these adverse outcomes and errors, all of it, to result in the smallest financial and medical consequences to patients. So if you look at this Venn diagram, as an economist, the concern is for where is there waste? Where are doctors and lawyers and patients spending effort for low returns? And clearly, those are the areas where there is legal effort in the pursuit of things that are not controllable. And so these would be area C, where there was no error and there's still a lawsuit, as well as area B, where there was no error and there was still a lawsuit. This would be what an economist would flag as economic waste. So let's go back to the goals of the malpractice system. We want to deter errors, and at this moment I want to flag the problem that providers are insured and they don't bear the full cost. So this whole idea of deterring errors is limited by the problem that the providers don't bear the cost. However, this isn't the only goal of the malpractice system. There is an enduring desire by society to compensate victims of a loss. Certainly, this could be viewed as a remedy to an unfair loss. If one has damaged property, this is remedied by restored property. In the healthcare setting, though, it's a little bit unusual that we believe it's possible to remedy the loss of health by money. This requires one to believe that health and money are some things that can be tradable. Another way to look at this compensation is that there is a special form of insurance. We want to control risks in society, and we just generally want health insurance. And this is a special form of health insurance. It's health insurance for those health conditions that are caused by medical errors. It's as though this is a special class of health outcomes that requires a special form of insurance. Imagine we had health insurance just for lupus, and one would buy an insurance policy if ever it became clear that one suffered lupus, and then you'd get a payout for that disease. Well, we're thinking here that malpractice-related disease is a special disease, and it requires society to create a special form of insurance. Finally, and this is really worth flagging, one reason we might have a malpractice system is the desire to give patients who feel anger because of a perceived injury a form of revenge. There is a valid emotion of anger if one feels that one has been harmed by a negligent healthcare system, and this desire to accomplish revenge has often led to these policies that give patients the ability to acquire revenge. There are other ways to do error deterrence. So if we think, and most economists feel, that error deterrence would be something to create efficiency, and as we mentioned in the quality lecture, total quality management and creating more mindfulness in the health system would deter errors. Peer review is a way to alert the medical care providers about ways that they could practice better, as well as informed consumers. If consumers were alerted to what to expect in a healthcare encounter, they could be their own advocates, and they could essentially police the system to make sure that they were getting good care. This goal of victim compensation could be accomplished through no-fault insurance. And in no-fault insurance, there is not a legal approach to this. There could be arbitration to have committees look at cases where there might have been an error and award victims monetary compensation when the arbitration committee decided that there was a reason to compensate the victim of a medical error. Now, this might soften the revenge motive. The revenge motive occurs usually from anger, usually due to the perception that the provider didn't care. And that motivation for many lawsuits is a lot of the reason that there are lawsuits. And in order to soften that revenge motive, many hospitals have disclosure protocols that would help the providers flag to the patient that there had been a medical error. And providers are trained to come to the patient and say, listen, there was a medical error in your case. And by telling the patient directly during the healthcare episode, it can often show that the health system did care, that they felt bad that this medical error did occur. Okay, now let's get into the economics. The gentleman you see on the slide is Judge Learned Hand. His parents named him Learned. I don't know why, but it's a fabulous name for a judge. Now, Judge Learned Hand is famous in health economics for being a judge who decided that there should be an economic criteria in controlling errors through the legal system. And he said that the amount of money that the healthcare system should pay to control errors, that is, C, the money spent controlling errors, should be the product of the probability of harm times the damage from the error. So if we look at that equation, Judge Learned Hand felt that that cost could actually both lower the probability of harm as well as lower the size of the damage. And he felt that there should be some equality, that we shouldn't just overspend, and he felt that there should be some proportion. And the legal system should try to award damages in proportion to the product of P and C. Now, economists are pretty thrilled that a judge just decided there should be some sense of efficiency, and we're thrilled that the Learned Hand criteria is out there. However, if one really wanted to do the economics, there would be a better version of the Learned Hand criteria. Here we see that the social cost of medical errors is the probability of damage times damage plus the cost of harm reduction. So if we really wanted to do the math on this, we would say that the total social cost equals P of C times D of C plus C. Now, if we were going to be economists and consult with Judge Learned Hand, we would do some calculus and say we want to minimize total social cost, and so we would do calculus to decide where we would find the minimum. And in calculus, what you would find is the equation shown, where you would find that the optimal amount of change in cost is the probability P times the change in damages plus the damages times the change in probability, and that should be equal to the change in cost. So PDD plus DDP equals the change in cost. In English, what the economic criteria would be to spend until the value of the next dollar spent on harm reduction equals the value of the marginal damage reduction plus the value of the marginal probability reduction. So when it comes to remembering the Learned Hand criteria, the thing to remember is that the legal system has already decided that there should be some efficiency, that the damages should be in proportion to the benefit in both altering the probability of damage and altering the size of the damage. Now, economists go further, and I wanted to come up with how an economist would view what has happened in the malpractice system. Economists would view the malpractice outcomes of errors as an externality. This is something that was not transacted by the patient and the provider. and both sides wanted an optimal outcome, which is having lower amounts of externalities. However, when we think of externalities, the optimal rate of externalities is not zero. We want to spend the right amount of controlling them, and that amount is not infinite. Now, given our math, the optimal rate is defined by the number of errors that can be achieved with reasonable expenditure of costs. So the optimal amount to spend on improving the healthcare system is the same as the one in the refined learned at hand criteria, that we should spend the little d big C up until the point where the change in the size of the damages times the probability of damages plus the damages times the change in probability, that has to be equal to the change in cost. So the marginal social benefit is on the right side, and the marginal social cost is on the left side. That's what we're looking for in the system. So shockingly, in a way, economists say that a perfect world would not have zero medical errors. It would have spent enough money on error control such that the benefit of the spending was equal to the marginal cost of the spending. Now, Ronald Coase, pictured here in the slide, says you can achieve this optimal outcome through a market approach if you assign the rights to either the providers or the patients, and if they can have transactions to each other in order to control the externality. And Coase says it doesn't matter how you assign the rights. You can either give the right to the patient or the right to the provider, and they can transact. And I think we've done exercises on the Coase theorem before, and I'm just pointing out that the Coase theorem applies to malpractice as well. So the corollary to the Coase theorem is that if you are looking at externalities in the system, you can conclude that property rights have not been assigned or there have been high transaction costs that are impeding the transactions between the injurer and the victim. And so the economic solution to externalities should be both the assignment of property rights and the reduction of transaction costs. So now let's reflect on, have we assigned property rights? Who owns the rights here, and who owns these malpractice insurance costs? Well, because there is malpractice insurance, here's the question, who has to fundamentally pay for the costs of errors in malpractice? Well, that is sort of baked into the entire system of payment in healthcare cost. The provider side is paying malpractice premiums, and they will, as much as they can, pass those premiums along in their fees to the patient. So essentially everybody is paying the premiums for this special form of insurance. And from an economic standpoint, we would like all of those payments for malpractice premiums to be resulting in a safer system that is deterring errors. And now we're noticing that if the provider doesn't actually pay out of their pocket, how are we going to deter errors? Well, one way that could occur would be experience rating. And there is, to some extent, a form of experience rating. Malpractice premiums are experience rated, but not experience rated to the individual. They are experience rated to the specialty. One could say that if you're a neurosurgeon, you pay higher malpractice premiums than if you're a psychiatrist, because the damages and the probability of malpractice is higher for neurosurgeons than psychiatrists. So there's this another way to say it, rather than your experience rated to a specialty, is that you're community rated within a specialty, that everybody who is a neurosurgeon basically pays the same rate. So among neurosurgeons, good neurosurgeons subsidize bad neurosurgeons, and good psychiatrists subsidize bad psychiatrists within the specialty, which really kind of undoes any of the incentive to deter errors within your specialty. The practitioner really fails to own the consequences of negligence. So just to give an example of malpractice premiums. Obstetricians pay about $45,000 a year, general practitioners $10,000, internists $12,500, pediatricians $12,500. Procedure-based specialties are more likely to result in malpractice payments, and so the insurance companies charge them more in order to cover the costs of their payouts. Now, it's not that there's no technical possibility. Insurers could definitely get data on claims per physician, and they could experience rate an individual physician, but they don't. And if you could think about why, one perspective on why we don't have individual experience rating is that, after all, this is primarily a victim compensation system, and that goal of the system is overwhelming the deterrence goal. There's also some idea that perhaps a lower malpractice rate would create an incentive. Is it really on the top of a physician's mind that if I would be more careful today, next year I will have a lower malpractice rate? Although some people who are facing experience rating in their automobile insurance might feel this way, it's really not quite come home that physicians feel this way, that foremost on their mind is acquiring a lower malpractice premium. Finally, I think we have to recognize that politics of medical lobbies would consider experience-rated individual malpractice premiums quite a threat to their ability to practice. The idea that you would suffer higher malpractice insurance premiums next year as a result of malpractice would have a chilling effect on the practice of medicine, because every day might be the end of your career if you get a malpractice judgment and face higher malpractice premiums. It would put you out of business. And so this creates a lot of incentive for medical lobbies to push against experience-rated malpractice premiums. Well, in any case, we do seem to have a system where there are weak incentives from the system to apply caution, that although the physician's utility function says that they value patient outcomes, this probably is the driving incentive for there to be caution in healthcare provision. Certainly because the doctors are insured against malpractice and they are not experience rated, they can pass through the malpractice premium to the patient, and there's really low incentives to supply caution in the system. Now here's a paradox. Even though we've looked at a system that does not really financially punish doctors say that the healthcare malpractice system is making them practice costly defensive medicine. How can this be? Now, the paradox is really resolved when we notice that it is emotionally quite harmful to doctors to be sued. Even though they may not pay money out of their own pocket, there's an emotional and a time penalty for having to defend a suit, to have to go to depositions and hearings and to soul search on whether they were negligent. Most physicians say that this is one of the most painful experiences they've been through. So there is an incentive for doctors to avoid these emotional effects of malpractice lawsuits. And this might be the reason they practice defensive medicine. Just to give an idea about whether there is truth to the theory of defensive medicine costs, I want to refer to a study done by Kessler and McClellan. They looked at tort reforms which lowered the expected damages in lawsuits. This was occurring across the country during the late 1980s. And what Kessler and McClellan did during this time is do an interrupted time series. They looked at total hospital expenses per heart attack patient during this period and tried to map out, did these expenses fall more or less in the states that enacted these tort reforms? So if a state lowered the damages in lawsuits, did the hospitals change how much they were spending in heart attacks control? Now, first they noted that, yes, the hospitals that faced lower damages did lower how much they were spending on heart attacks. And fundamentally and importantly, they found that the outcomes did not get worse. So it was possible after tort reform to spend less and not hurt anybody. This means that because of the higher costs of lawsuits prior to the reforms, hospitals were overspending on heart attacks for no advantage to the patient. They were just doing more things to heart attacks that were not creating benefit to the patient, but simply raising costs. I want to raise a concept that's important when we think of error deterrence, which is the idea in the reading that there are bad apples. The bad apple idea is that malpractice risks are not uniformly distributed among doctors, that they are concentrated among a subset of doctors that seem to be continually making medical errors. And some evidence from California is that 46 out of 8,000 doctors made 10% of the claims in their malpractice system and were generating 30% of the awards. This is a general phenomenon in a lot of insurance, and it's certainly true in healthcare insurance. It's also true in malpractice insurance, that a small subset of those who are insured are generating most of the costs. When an economist sees this type of phenomenon, there's an efficiency incentive to try to find a way to move those bad apples out of the system. But we've just gone through the constraints, and the constraint is the power of the medical lobby to try to protect against experience rating. The other pieces of the system are for there to be system changes so that the hospital system and the professional societies can find these bad apples and remedy them without the malpractice system. And so these would look like medical licensure systems that find the bad apples and have the licensing board of California ask doctors, have you been sued in the last few years? And then to find negligent physicians that perhaps deserve their license to be revoked. And medical licensing boards are in this space trying to remove the bad apples through the medical licensing system rather than through the malpractice premium escalation. So I want to start a new topic, which is the idea of cycles of malpractice crises. Throughout your career as a health economist, you will see cyclic crises in malpractice. You will find physicians saying the malpractice premiums have risen too high and we need to have reform. These will happen repeatedly over 5 to 10 year cycles. What I'm showing you on this slide is the basic profitability of any insurance system. These are an index of profitability for a bundle of insurance stocks. And you can see them going up and going down and going up and going down. Now, the business cycle is really underlying this. And insurance companies are very pro-cyclical, meaning whenever the stock market goes up, insurance stocks go up and vice versa. If you think about why, remember what insurance companies do with their capital. Every year, insurance companies are making a substantial amount of their profits because of their reserves that are planted into the stock market. So if the stock market is high, insurance companies have a lot of capital flowing into their system. And when the Dow Jones falls, the insurance companies are tight on their money. So if we go through what we know about insurance companies, their basic system was to collect lots of money in premiums, then put it in the stock market or lend it to banks to make more money, and they just hope they don't have a lot of payouts. The cyclicity in their returns drives them to have cycles of high premiums. These high premiums come to some extent because of an undersupply. During downturns in the economy, some insurance companies are exiting from bankruptcy. Those who remain are also facing tight money because their stock returns are down, and so they might start to edge up on their premiums. And then in the malpractice component, you would see physician groups saying, we can't afford malpractice premiums anymore. So the business cycle is going to drive cyclic changes in insurance premiums, which is going to result in cyclic crises where physicians say and hospitals say, we can't afford our malpractice premiums. And so we'll have cycles of tort reform where the legislators will be asked for caps on the pain and suffering and damages. And the public will recurrently debate whether their malpractice system is all it could be and whether it's doing what it should in deterring errors. So let's summarize what we've covered today. We've covered a review of a malpractice system that economists recognize has two separate economic objectives. One is to simply form a compensation mechanism, essentially insuring patients against a special form of disease, the disease called medical errors. And it simply collects money from the patients in the forms of hidden fees in the medical fees that are used to pay for premiums. And it puts that money into the malpractice system and then awards it to patients who suffer this disease. I think we've seen that as a compensation mechanism, it's pretty inefficient and sloppy because of the disconnect between suffering a medical error and actually becoming awarded damages. We also see that as economists, malpractice should and could have a large deterrent effect on helping the healthcare providers feel the financial consequences of carelessness. And yet we see inefficiency here as well because the providers are not personally experience rated. Their specialties are rated, and specialties pay more if they're high-risk specialties. So the individual deterrent effect is really related to the emotional consequences of being named in a malpractice suit. So our economic perspective stresses these inefficiencies, and from the Coase theorem, we have an incentive to try to lower transaction costs between injurers and victims, and looking at the system to find other systemic incentives to reduce errors. And we would go back to our quality lecture from last time to say to the system, let's be more mindful of where these errors are occurring, and let's do system changes in order to make errors less likely. And this would be the most promising source of reducing many of the costs of medical errors in the system. So I'd like to thank you for listening and hope that you found this lecture useful. Thank you.